Hello and welcome. We hope everyone is doing well. Even with COVID-19 happening, we hope that everyone is safe and healthy, and we thank you for taking the time to join us. My name is Lorna Nealand, and I'm the Director of Engagement at the Swedish Foundation. The Foundation is the fundraising arm of Swedish, the largest nonprofit healthcare system in Washington, and we're based in Seattle. I'd like to take a moment to thank our donors who are joining us today. Without your support, we can't continue the innovative work we do every day for our patients. This is our third in our series of virtual webinars for women's wellness. We hope you were able to join us in September for the Menopause webinar and in October for the Heart Healthy webinar. And if not, we will have links at the end of the call. This Women's Wellness series promotes our vision for the Women's Health and GYN Specialty Services. An extension of Swedish, the program will provide comprehensive care for women at every stage of life, including primary care and behavioral health, wellness and prevention, and specialty and surgical care. In regard to how our time together will proceed, we will be talking with our physicians about changing health needs and healthy maintenance for women by each decade. Let's take a look at the poll. So it looks like we have, looks like our top group, 30% is between the ages of 50 and 59, and then 28% between 60 and 69. And then we have women who are 70 and up at 19%, and then women who are 40 to 49. And then we have some women who are joining us who are 39 and under. I see that we have a range of women of different ages today, and we will be addressing age ranges starting at 40, but feel that this is informative for women of all ages. This event is also meant to be interactive, so please enter your questions in the Q&A. We will answer your questions throughout the call and at the end. Now I would like to introduce Dr. Tanja Sorensen, the Executive Medical Director for Women's Services at Swedish, to talk about the vision of this new and exciting program.
Thanks, Lorna. And thank you everyone for joining us. We appreciate your time, and I think you'll find this really interesting. We've got a couple of great speakers today. As you maybe heard before, Swedish aspires to become the primary destination for women's health and GYN specialty services in the region. Our model focuses on coordinating care that focuses on prevention, wellness, and aging, healthy aging. Last year, before COVID, we were able to assemble a couple of different groups of very dynamic and engaged women to share their concerns and questions about healthcare needs as we go from our childbearing years into our middle years. And the themes that we heard really were that women want somebody on their healthcare team who's their advocate in seeking answers and helping them coordinate their care. And this would include taking a holistic approach that would include wellness, nutrition, acupuncture, stress management, in addition to more medical needs. The program will focus on, will provide comprehensive care for women in every stage of life, including urogynecology, primary care, cardiology, mental health, wellness, prevention, and specialty surgical care. As we continue to build and launch this program, we are relying on our community for support. The COVID epidemic, in addition to being a devastating public health event, has also been very hard on our healthcare system in terms of finances. And now more than ever, we really appreciate your support. I'm really happy to announce, for those of you that aren't aware, that we received a $250,000 gift as seed funding for our program. We can't do this innovative work without you, especially at this point in time. Today, we're going to hear from Dr. Rebecca Dunsmore-Sue, who's the Medical Director of Swedish Women's Healthcare and GYN Services, and Dr. Tanja Nazemi, who's a urologist at Swedish Urology, as well as, and Dr. Nazemi is a urogynecologist, to be specific. and Dr. Carrie Rubenstein, who's the Geriatric Medicine Fellowship Director at First Hill Swedish Family Medicine. So I think that all of these roles are really important as we are forming this coalition of providers and services to make our vision happen. So I think that you'll find it really fun and interesting to have a back and forth and questions answered and really great information. Lorna, can I turn it back to you?
Absolutely. Thank you so much, Dr. Sorensen, for joining us. I would like to officially welcome Dr. Rebecca Dunsmore-Sue, Dr. Tanya Nazemi, and Dr. Carrie Rubenstein. Thank you for your taking time out of your busy schedules to be with us. And if I can have all of you go off mute, we would love to have a conversation about healthcare needs and health maintenance for women by each decade. But before we begin, I would love to ask each of the physicians to tell us a bit about yourselves, your journey, your current practice setting, and why did you choose to focus on women's health? Dr. Dunsmore-Sue, can you start?
I'm happy to, Lorna, and I hope everyone can hear me well. So I am an obstetrician gynecologist. I did all my training on the East Coast and then moved out to Seattle in 2005 to the University of Washington as faculty. And then later around 2012, moved over to Swedish, doing inpatient work, and then started a small private practice in menopause, and then which now has become sort of a Swedish practice focusing on menopause, vulvovaginal specialties, and gynecology specifically. And my transition into this work really started with residency, because I was blessed to go to a residency where menopause was considered a subspecialty, and we actually learned that in residency, which can be hard to find. And I've just always been fascinated with hormones, endocrinology, and gynecologic care of women, so that it sort of fit right into my wheelhouse to come on board with this program when Swedish was looking to start it.
Thank you. Dr. Nazemi.
Hi. Okay.
Hi.
Can you hear me okay?
Yeah.
So my name is Tanya Nazemi. I'm a urologist. I was originally from Texas, where I did all my medical school and did my residency in Nebraska. And then I moved to Seattle to do fellowship training in pelvic floor reconstruction. And then I practiced on the east side at Evergreen for several years before coming to Swedish. And one of the reasons I chose urology is that just in general, women tend to be underrepresented in the field of urology. About less than 10% of all practicing urologists in the United States are women, but obviously half the general population of patients are women. And I found that there were a lot of women that were avoiding seeking help for their urologic problems because they were uncomfortable seeing male providers. And there was this unmet need for female urologists. And I wanted to be able to provide that service to allow women to seek care for their urologic problems in a more comfortable setting. Here I am.
Wonderful. Welcome. Dr. Rubenstein.
Yes, thank you. Thanks for having me, and thank you all for being here. My name's Carrie Rubenstein, and I was trained as a family physician here at Swedish, and then went on to do specialty training in geriatrics. So while I take care of both men and women and all age groups, I really love taking care of older adults, and I am a clinician educator. So I work in the residency at Swedish Family Medicine, and I direct a fellowship for specialty training in older adults. And it is really a pleasure to both be able to be a primary care provider and also a consultant when it comes to specialty issues in aging. So thanks again for having me.
Thank you. Gosh, we are so lucky to have all three of you here. Thanks again. Dr. Dunsmore-Sue, first, can you tell us how primary care and OBGYNs work together to best care for women as we age?
Thanks for that question, Lorna. I think sometimes there is confusion among our patients who they're supposed to go see and when. And I think OBGYNs and primary care work very closely together to care for women, especially as they age. Women know when to see an OBGYN like during their childbearing years. You know, they come for their exams, they come for pregnancy, they come for things like that. They come for gynecologic surgery or gynecologic issues. And then as women exit sort of the main bulk of their childbearing years, it becomes a little bit more nebulous where one ends and the other begins. A lot of primary care doctors do an excellent job of doing annual Pap screening, annual pelvic exams, annual breast exams, and that's great. In that case, you know, a gynecologist might be needed if there's something more complex going on, or surgery might be indicated, or there's some abnormalities in the Pap smear that go beyond what a general practitioner might do. A lot of it's just comfort as well. Some women continue to want to see their gynecologist every year for their Pap and annual and breast exam, and that's fine too. You know, some of us have specialist training in hormone replacement therapy, like myself. And so that might be a time when you want to come and talk to a gynecologist who's sort of up to date on the most recent studies that have come out just that year. And sometimes your primary care may be comfortable with that as well. We really do try to work very closely together. And I know, especially within the Swedish system, I'm really blessed because there are lots of great primary care doctors who do this work and do it well. And so we can send our notes back and forth, and we can really collaborate rather than be at odds with each other.
That's great. And that's really good to know. I was thinking, why don't we, but before we start talking about women in our 40s, why don't we offer 2 polling questions to help guide the conversation? So the question is, which of the following are a good source of dietary calcium, pardon me, check all that apply. Again, which of the following are a good source of dietary calcium? Your options are dairy, fish, meat, leafy green vegetables, root vegetables. Again, check all that apply. And then there's a second question, true or false? Are supplements a better way to get doses of key nutrients like calcium and vitamin D? So take a moment to do that, and then we'll see what the results of the poll are. Give it a few more minute or two. Great. So again, which of the following are a good source of dietary calcium? So it looks like dairy, all of you selected dairy, 38% of you selected fish, 11% meat, 9% leafy green vegetables, and then 24% root vegetables. And then true or false, are supplements a better way to get doses of key nutrients like calcium and vitamin D? So 31% of you said that's true, and 69% of you said that is false. So Dr. Rubenstein, can you let us know what are the good sources of dietary calcium? And what is the best way to make sure that we're getting enough calcium and vitamin D? And then I always like to know, why is this important?
Well, let me start why it's important. You know, calcium and vitamin D, of course, help make sure that our bones are strong, and strong bones lead to healthy bodies, less likelihood of falls and fractures. And what's really interesting, now going to the second polling question, is that we've found that getting calcium and vitamin D in the diet is best. If you can get the sufficient amount of calcium in your diet, you don't need to take supplements. And so then the question is, how do we get the calcium in our diet? And you're aiming for about 1,200 milligrams. And you know, when you think about dairy sources, I think that's the most common. Everyone got that 100%. If you get 2 or 3 servings of calcium, you're sort of dairy sources of calcium, you're sort of well on your way with yogurt, cheese, and milk. I think, you know, that tends to be not necessarily a big source in some people's diet, especially if you're dairy intolerant, but I would say that's like the highest source of dietary calcium. And then non-dairy foods that are high in calcium, fish is one of them, salmon particularly. And then a big one is greens. So spinach, turnip greens, collard greens, you can get about 150 to 200 milligrams in a serving of those. And so putting all that together, and you can get calcium and other things too, but in smaller amounts, like root vegetable, like potatoes, about 30 milligrams. So if you have a varied diet, then you can probably get 1,200 milligrams. But it takes a little bit of thought and a little bit of calculation as we go along. In terms of vitamin D, there are some foods that we can get that are high in vitamin D, but a lot of vitamin D, and salmon is another example, fortified milk and cereal are other examples, but we get a lot of vitamin D from the sun. And it's, here in Seattle, it's unlikely you're going to get sufficient amount, especially in the winter, of vitamin D from the sun. At noon in Miami in the summertime, in 15 minutes, you can get your daily allotment of vitamin D. That's not going to happen here. And so we recommend, there's sort of a large range of recommendations in terms of vitamin D, but starting at 800 international units, and up to about 2,000 a day if you are not vitamin D deficient is reasonable. And taking a supplement is very reasonable, especially in the winter time, although there's varied recommendations and guidance about how much.
Okay, yes, because that, I get a lot of sun and I have to take a lot of vitamin D as well. So that was going to be my question is, how much do we take? But it sounds like we should just talk to our physicians, and based on what our numbers could be, I'm assuming the recommendations could be made that way.
And some of it depends on whether you have a diagnosis of osteoporosis or you have other conditions that make you at risk for vitamin D deficiency. And that's a discussion you're going to have with your physician and healthcare team. Great.
Thank you so much. Dr. Dunsmore-Sue, so can you tell us about the difference between all the different screens that we do in our 40s, mammograms? There seems to be a lot of different recommendations of when to do that. And now we're hearing that colonoscopies for women in their 40s. Can you address that?
I can try. It's a complex landscape, and I'll be honest. So we get recommendations from different places when it depending on which test we're talking about. So let me start with mammograms. Mammograms, there are several different places that make recommendations about mammograms and when to start and how often to do them. So the three I tend to look at when I'm talking to my patients about when to start and how often to do it are the American Cancer Society, American Congress of Obstetrics and Gynecology, or ACOG, and then the U.S. Preventative Services Task Force, which is sort of a government body that brings recommendations together. And I'd say the way I present it is that they all sort of say you should start at a slightly different time. Some say 40, some say 45, some say 50, but all of them qualify when they make that recommendation. And what they say is between 40 and 50, it's a conversation. Do I start getting a mammogram? How often do I get that mammogram? Is it yearly or every other year? And a lot of that depends on, your balance of risk factors, as well as your comfort with, the fact that if you start getting mammograms earlier and very frequently, you may get more biopsies in the process. And the biopsies that you get in those early years are less likely to yield a diagnosis of cancer. So it's a harm-benefit ratio that you're really talking about. And we know that women in their 40s tend to have denser breasts as well. So you may end up getting extra studies or biopsies just because we can't see well enough. That being said, some women just feel more comfortable getting an annual mammogram from their 40s on, and that's okay too. Like I said, it's a conversation. After the age of 50, we really do recommend mammograms. But again, different recommendations from different societies say whether it should be yearly or every other year. And I sort of have a conversation with my patients about that as well. I tend to recommend a yearly mammogram after 50, but it's not unreasonable to make the decision understanding the risks of doing an every other year mammogram. And then they ask us to stop at some point. So when do you stop getting mammograms? The recommendation may sound a little crass, but it's really, you should continue to get mammograms as long as it looks like you have at least 10 more years to live. So seems like a strange recommendation. Really what they're trying to get at is the fact that breast cancer does actually take a really long time to grow into something that's going to become far enough advanced that it can take your life. So there comes a point at which there's no longer benefit in screening for low stage cancers. You should always do a mammogram if something is felt or palpated, or if there's some suspicion that something is going on. That's a different scenario. What we're talking about here is screening and looking for those small things that we can't otherwise detect.
And then obviously family history plays a part in that conversation.
Family history, genetics, there's all sorts of things that go into how we make screening decisions. Yes, and that's why it's a conversation.
Okay.
Pap smears, another fraught and varied recommendation landscape. And I will say that most societies, so that's ACOG, the U.S. Preventative Services Task Force, and then there's another group called the American, it's ASCCP, and I'll probably get it wrong, but anyway, they focus only on abnormal pap smears. They tend to recommend one way. There's a recent recommendation from the American Cancer Society that is based on some modeling of data that I think most of us are sort of taking as not what we would follow as a recommendation. So I'm not going to go into that one because I don't like the recommendation and I don't like the data it's based on. So, and none of the other societies have adopted it yet, just, you know. Pap smears, right now the recommendation is from 21 to 29 that women get pap smears without HPV testing. And HPV is human papillomavirus. It's the virus that causes cervical cancer. Every 3 years, although some people do them every 1. That's if everything is normal on these paps. So all the recommendations I'm giving you are for people who have had normal paps. And then from 30 to 65, the recommendation is that you can either do pap screening every 3 years or co-testing, which is testing a pap and an HPV test every 5. That seems like a huge space to women who are totally used to getting annual paps. The reason is we have just such a much better understanding of how cervical cancer comes about and how long it takes a positive infection with human papillomavirus to turn into abnormalities and then turn into cancer. That being said, I tell my patients that if you feel more comfortable getting an every 3-year pap, if you feel more comfortable getting an every 1-year pap, I will do it. We may see more things that we end up treating that maybe didn't need to be treated. I don't know that it actually prevents cancer to do it more frequently, but if there's a comfort level, I will do it. And generally, we're seeing insurance companies cover them. They still haven't sort of transitioned to the new recommendations. After 65, they actually recommend, as long as a woman has been getting regular paps and they have been normal, that she stop getting paps. And that's really based on the fact that while 20% of cervical cancer occurs over the age of 65, it occurs in women who haven't been regularly screened or who have had abnormalities previously. In women who have had regular normal paps, we really just don't see cervical cancer after that age. And it's a combination of factors, including how their cervix is formed and the likelihood of acquiring HPV and turning it into something else. It's not because we don't care about women over 65. We're just trying to avoid a test that may have unnecessary downstream biopsies and such, because over 65, it can be harder to get an adequate pap and harder to, you may end up with more paps than a year because we just can't get enough cells. There are a lot of reasons why we make that recommendation. That being said, if my patient comes to me and says, hey, I still want a pap at 70, I will do it. It's, you know, that I'm happy to do that.
Okay.
The other recommendation I meant to mention is that women who've had a hysterectomy, so the removal of their uterus and cervix, because pap tests test for cervical cancer, and that hysterectomy was not done for anything related to HPV disease or precancerous cells, then they can actually stop getting pap smears because it tests for cervical cancer and you haven't got a cervix.
Exactly.
I'm going to very quickly talk about colonoscopies and sort of leave that to the side. We've traditionally recommended colonoscopy start at 50 with a qualification for African Americans might need to start earlier. There is some recommendation that we may need to start everybody earlier around the age of 45, but I don't think it's been fully adopted yet. And I'll let Dr. Rubenstein sort of address that a little bit too. I think that recommendation is actively changing. So it's something we just need to keep an eye on.
Great. Thank you so much. Okay, so that was a lot of information. And I want everyone to know that this is being recorded, so you can go back. And then we'll also take little nuggets out of today's presentation, and we will send an email out to everybody. And then if you, again, have questions, feel free to put them in the Q&A box, and then we will try to address them as we go. And also we can address them afterwards as well. So just know that. So Dr. Dunford-Su, thank you very much. So Dr. Nazmi, can you tell us about how we work through stress incontinences and what interventions can work?
Sure, absolutely. So, so stress incontinence is leakage of urine, and it typically occurs in women when they are increasing the abdominal pressure or stress on the bladder. So it's very specifically associated with an activity. Oh gosh, I feel a sneeze coming on. Let me cross my legs because I know it's going to force the urine out. And it does tend to occur a little bit more frequently after child bearing and as our hormones start to fluctuate a little bit. But the reality is it can happen in women of all ages, whether or not they are actively menstruating and whether or not they've had children. And so what happens is as you are pushing on the bladder or bearing down or putting pressure or stress on the bladder, some of the support of the urethra is lost and it can force the urine out. And so when we talk about management symptoms, first of all, it's very important to understand that even though it tends to be more common as we get a little bit older, it doesn't mean that you have to live with it by any means. And it's very treatable, and there's a lot of things that you can do both on your own and with the help of a provider. So from a general standpoint, things that all women across the board who are struggling with stress incontinence should address is just general health guidelines. Weight loss is very important because it relieves some of the pressure or stress off of the bladder. And you don't really need to lose a lot to see a big difference. So if you lose just 8% of your excess body mass index or excess weight, you can see sometimes up to 50% improvement in your bladder symptoms. I mean, a little bit goes a long way. The other thing that's very important is you don't want to smoke. That's obviously important for many different reasons, but from an incontinence standpoint, it's also important because smoking, it diminishes blood supply, it makes the tissues very thin and weak, and plus it's just bad in general. Everyone talks about Kegel exercises. This is sort of a very nebulous and vague term, but basically what it involves is strengthening your pelvic floor muscles. So that if you do cough or sneeze, if you have really strong resting muscle tone of your pelvic floor, you can hold it in. And it's difficult though for us to do a Kegel because the reality is that's not really something that they taught us in gym class when we were going to high school. And you can't go to your gym and pick up a weight and say, here's my pelvic floor Kegel. And so one of the things that's also very beneficial that I always encourage my patients when they come to see me for stress incontinence is, in addition to, again, weight loss and general health measures, is to see physical therapy. And so there are actually women who are physical therapists who are very specifically trained in pelvic floor rehabilitation and strengthening. And it's always a good start because, of course, there are surgical procedures as well. And while nobody ever wants to jump into surgery, we have a lot of surgical procedures, outpatient procedures. Some are a little more invasive than others, but oftentimes very successful in managing symptoms that don't respond to these conservative measures.
Thank you very much. That's very informative. So again, I just want to stress that this is a lot of information. We will be providing a recap at the top areas we need to focus on at the end of our time together. And we'll also be sending out an email with information of other resources. So thank you very much for all that information. So let's transition to talking about healthy aging for women in our 50s and what should be done during our 50s to continue our healthy aging. So let's do another poll. Which of the following interventions help with pelvic health and urinary continence? And check all that apply. So your choices are Kegels, diminishing, or rather drinking a lot of water, avoiding caffeine, cranberry juice or extract, and physical therapy. So take a moment to fill that out. Which of the following interventions help with pelvic health and urinary continence? guys are fast. Thank you so much. So we'll show the results in just a moment here. It looks like Kegels here at the #1 spot at 96% is an intervention. Physical therapy at 88%, avoiding caffeine, 68%, drinking a lot of water, 56%, and drinking cranberry juice or taking an extract at 34%. Dr. Nazmi, so this is really in your wheelhouse. Can you tell us, and I know you touched on this for our last section, but tell us which interventions help, and also about urge incontinence, perhaps overactive bladders, signs and management.
Okay, great. So I think everyone did a really good job answering those questions, and you all were all spot on. So again, there's a couple different types of incontinence. There's the stress incontinence, which we just discussed, which is again always associated with some sort of activity where you're increasing the pressure or stress on the bladder. That's a little bit different from overactive bladder, or what we call urge incontinence. So this is different. This is oh, I feel like I need to go to the bathroom, so let me start to walk there. And as I see the toilet, it just wants to come out, and I have to pull my pants down because it's already coming out. Or if you get home and you get the key out, like you're about to open the door, and suddenly you have to drop your groceries and run to the bathroom. Or sometimes you're just washing your hands or doing the dishes and suddenly you're wet. So this is not necessarily incontinence associated with pressure or stress on the bladder. The bladder itself is just squeezing the pee out whenever it feels like it. And that is different from the stress incontinence. And the management options are also a little bit different in some regard. Now, definitely weight loss and smoking cessation are also applicable. Overactive bladder oftentimes tends to be associated with things in our diet, which is where the caffeine comes in. And I always tell people caffeine is not unhealthy for you in any way, but it is a bit of a stimulant, and it certainly can stimulate your bladder in addition to other things. And while it is not an unhealthy chemical, there are certain foods like caffeine, or foods and drinks like caffeine, that can stimulate your bladder and make it a little bit more spastic and overactive. So avoiding caffeine or spicy foods or acidic foods or carbonated drinks or alcohol can again sometimes help reduce that spasticity or overactivity and reduce that urge or overactive bladder. Again, these things are not unhealthy for you. They just sometimes may make your bladder a little bit more unstable and erratic. The pelvic floor exercises do help as well, along with the physical therapy and the weight loss, because again, it helps to improve your resting muscle tone so that even if you do feel the urge to urinate and you're trying to get to the bathroom right away, your pelvic floor muscles are actually strong enough to hold it in. And so these are really good initial interventions to take, again, on your own to help reduce your spasticity or overactivity and random leakage episodes when you're at the grocery store and you can't find the bathroom in time, which is very frustrating and very alarming. And so those are the first steps as well. Again, there are additional management options, procedures, medications, nerve stimulators, injections, etc. So there's a lot of intervention available for that as well. Drinking a lot of water and the cranberry extracts are also good for bladder health. We'll talk about that a little bit more in another section, but as far as a continence issue, I will tell you this: a lot of women particularly who have overactive bladder, they pee frequently. They try to actually dehydrate themselves and restrict their fluids because they don't want to have to go to the bathroom as often. And that's counterintuitive, and it actually can actually cause a little bit more issue in the long run, because if you dehydrate yourself, well, that puts you at risk for urinary tract infection. And urinary tract infections can definitely increase the overactive bladder urgency frequency component as well. But the other thing that happens is when you're dehydrated, your urine is very concentrated. And when it becomes very concentrated, it becomes much more irritating to the bladder itself. And so interestingly, if you dilute your urine and you drink more water, a lot of women will tend to feel less urgency to urinate, and they're able to hold it longer. And then when they go to the bathroom, they have a more satisfying urination because they're actually getting a good amount out each time they go, as opposed to going every 5 minutes and just getting a small amount of really dark, concentrated urine. So drinking a lot of water, agreeable.
Oh, that's a lot of really good information. Thank you very much. So let's transition to vaginal symptoms in our 50s. Dr. Dunsmore-Sue, what changes should we expect or are actually experiencing in our skin, our hair, our nails, and also we had somebody ask about the libido.
Ah, yes, that's a big box you just gave me, Lorna. Let me start with the vaginal symptoms because I think that's really important to recognize. And a lot of women think that nothing can be done when actually there are a lot of great interventions that can really help us maintain those tissues. So as our estrogen reduces in menopause, and it sort of fluctuates for a while during perimenopause and then goes down as our ovaries finally stop making it. One of the things that can happen is about a year or two into that menopause, suddenly vaginal symptoms seem to appear. And the reason really is that it takes a little while for those tissues to adapt to the new hormonal status and change. We used to call this vaginal atrophy, which sounds horrible. And technically that describes what's happening to the tissues, but now we tend to refer to it as genitourinary syndrome of menopause. And the reason we do that is because we recognize that it's not just the vagina, it's not just the external structures of the vulva, but also the urinary structures. They're all estrogen responsive, and they will change how they behave as estrogen goes down. So the symptoms that women can come up with are things like just daytime burning or itching. They can have pain with intercourse. Some of the urinary issues that Dr. Nazemi has been discussing can increase suddenly. And the nice thing is we have lots of great things that we can do. We tend to start with non-hormonal interventions like vaginal moisturizers with hyaluronic acid, which can be really helpful for moisture and just nice sensation. Some women find that lubricants for intercourse are all they really need. But other women, those are not sufficient interventions. So then we move on to more complex interventions. A lot of time, the first step we go to is a vaginal estrogen. And I want to make a really important point here. These are ultra low doses of estrogen. So these are doses that are considered safe to use even in women who've had breast cancer before that was estrogen responsive, because really you're not absorbing them into your systemic circulation. We're just using them at the level of the vagina. And so those vaginal estrogens can be really helpful in helping those tissues get a little more elastic, have some collagen, just be a little bit more resilient through menopause. There are other things we can do. I use a laser in clinic, for example, but there are a lot of great interventions. And what I tell women is you don't need to live with these symptoms, especially pain with intercourse. A lot of women think they just have to live with it. And that's absolutely not true. I'm going to segue a little bit into the libido portion of this. Libido is a huge complex box in women. We tend to have responsive desire in general, and I'm making a gross generalization here. Some women are very different than others. But the things that impact our libido, especially as we age, are whether or not there's pain with sex. If you have pain with something, you don't want to do it. It's a pretty normal and natural response. Stress really does tend to turn on the red light towards libido. Lack of sleep, which can be a huge issue in your 50s as you transition into menopause. There's a lot of insomnia and night sweats that can impact sleep. A woman who is tired wants to go to sleep. She doesn't want to have sex. How we feel about our bodies, how we feel about our body image, whether we feel sexy has a huge impact on how we feel about sex. The hormone is a very small portion of that libido change. And so, having a conversation with someone who really understands all these factors and has lots of great hints is great. And we're lucky to have Dr. Ashley Fuller at Swedish OB/GYN First Hill, who's a huge expert. I do this all the time as well. It's just like something we really can deal with. And I think you asked one more question. Oh, skin, hair, and nails. Yes, also estrogen sensitive. Basically everything in your body is estrogen sensitive. I just, to tell people the truth. But people tend to sense skin dryness, sometimes brittle nails or hair thinning. And while I usually tell people that's not a reason to start systemic hormone replacement therapy, if you're starting it for some other reason, that will be helped by that. Those changes tend to get better over time. Your body just gets used to a new normal. And so the dryness and the hair and nails do tend to improve over time through menopause.
Well, that's great news that there's, interventions that we can do. So thank you. Dr. Rubenstein, Dr. Dunsmore-Sue touched on colonoscopies in in our 40s. But I'm wondering if you can talk more about bone scans, because I think it's called DEXA scans. Is that how you say it?
Yes, DEXA scan, yep.
Okay, thank you.
Let me just add a couple of things, if I may, about colonoscopies.
Sure.
So it's that same organization that Dr. Dunsmore-Sue mentioned earlier, the USPSTF, who is currently reviewing guidelines on changing the time we screen for colon cancer to 45 for everybody. And their modeling and their predictions is that there will be lives, not necessarily lives saved, but years of life improved with earlier screening. And so that may be something that you'll be talking to your providers about in the near future. And then also just to understand that we believe that once yearly stool testing, we call it the FIT test, fecal-immunochemical test, you have to do that annually, as opposed to a colonoscopy, which you have to do every 10 years if it's normal, is safe and effective in terms of screening for colon cancer. And again, it's something you're going to talk to your doctor and healthcare team about. I know that I have some people who are choosing to do that now during the pandemic, their annual stool card testing, as opposed to going in and getting a colonoscopy. And depending on your risk factors, it's a reasonable thing to talk to your healthcare team about. In terms of DEXA scans, so DEXA scan screens for osteoporosis. Osteoporosis is a bone disorder that is more common as you age. And the biggest problem with osteoporosis is that it puts you at risk for fractures if you fall. And I think everybody knows somebody who has had a hip fracture and then declined and did not do well afterwards. That is certainly not everyone, but it's something that we work really, really hard to prevent, is fractures as you get older. And so generally speaking, we recommend this DEXA scan, which is just a specialized X-ray for people 65 and older. And younger, in your 50s, if you have certain risk factors. And again, you're going to be talking to your healthcare team, but smoking is a risk factor, excess alcohol use, low body weight, premature menopause, long-term use of certain medications like steroids would make you want to get that DEXA scan earlier. And again, really, really important. And this is one of the few screening tests that you're never too old to get. And the reason is because it increases sort of exponentially the osteoporosis as you age.
Thank you very much for explaining that. So because there's a lot of common themes through each of the decades, and I should say for those joining us a little bit late, we started with the 40s. We've been kind of weaving through different decades, but we're currently in the 50s, and we're going to transition into our 60s. And again, a lot of common themes, but there's other things that are more prevalent in your 60s. And Dr. Nazemi, can you tell us why it seems that when women in our 60s, we tend to have more frequent UTIs, and what can we do about that?
Yes, absolutely. I could spend hours talking about UTI prevention.
Yeah.
So it is hands down the number one problem that I see in my medical practice. So urinary tract infections tend to be more common in women who are in their 50s, 60s, because of menopause. So as Dr. Dunsmore-Sue was discussing all the different things that occur in our bodies when we lose our estrogen, one of the things that also occurs when we lose the estrogen in the vagina is that we lose some of the protective effect that it has for helping reduce our risk for infection. So in the vagina, estrogen allows the environment to be very acidic. It makes it have a very low pH. And bacteria cannot live in acid. And so when we lose our estrogen in the vagina and we lose the acidity, we get overgrowth of bacteria in the vaginal tissues. And the urethra, which is the channel where the urine passes, is also very sensitive to estrogen. And so when we lose some of the estrogen in the urethra, we lose some of the tissue quality as well. So I try to explain it like if you have a bar of soap that dries out and you get little cracks in the dry bar of soap. So similarly with the dryness in the urethra, you get these little microscopic cracks. So that in combination with overgrowth of bacteria in the vagina allows for bacteria to pass more easily into the urethra. So lack of estrogen in the vagina is one of the main risk factors for women who have gone through menopause to get recurrent urinary tract infections. There are other things as well. So there are general measures that all women should take to help prevent infections at any age, but in particular when they've gone through menopause. So as we discussed before, a lot of women will actually dehydrate themselves in order to urinate less frequently, and that can increase your risk for infection. So you definitely don't want to hold your urine for extended periods of time, because even if bacteria go up into the bladder and urethra, if you can flush them out quickly enough, then they don't have a chance to colonize and multiply. So hydration, urinating frequently, the vaginal estrogen that we discussed, constipation is a big risk factor for urinary tract infections. So you need to poop regularly. Always urinate immediately after intercourse, because again, that's the time when bacteria will oftentimes get pushed up into the bladder and the urethra. Some women will try to urinate before intercourse and then have intercourse and then urinate after, but sometimes the bladder is just not full enough to have a good forceful stream after they have sex. And so it's kind of nice to have a comfortably full bladder at the time of intercourse so you can have a more forceful stream of urine. The other thing is a lot of women who develop recurrent urinary tract infections think that they're unclean in some way and that it's a hygiene issue because they're getting bacteria in their bladder and the urethra. And then what ends up happening is they try to clean themselves more. They buy special washes or wipes or vaginal douches or cleansers and try to clean themselves to reduce their infection. And what they're doing is they're disrupting the normal vaginal environment, and they're actually raising the pH and making themselves more prone to urinary tract infections. So less is more in that area. Just water and pat it dry and leave it alone and just urinate frequently. I do want to spend just a brief second to talk about cranberry supplement because it's very common. Our grandmothers always taught us to use cranberries. It's sort of this old wives' tale. And somebody actually asked a question about it. And the answer is yes, there is some data to support cranberry. So what it is there is an active ingredient in the cranberry, and it's called proanthocyanidin, or PAC. And what this ingredient does is it helps to flush bacteria a little bit more easily from the bladder. So that if bacteria go up into the bladder, in order for them to colonize and start to cause an infection, they actually have to stick to the lining of the bladder wall. And this PAC helps to make the bacteria flush out a little more easily and make it less sticky. The problem is that all cranberries are supplements. It's sold as a supplement and it's not really FDA regulated. And so they can actually put whatever they want in the cranberry supplement. And what you really want is you want this active ingredient. This is what's going to reduce the chance for infection. And so if you were going to take a supplement, you would want to look for this ingredient. And there are several that you can purchase online. Sometimes they have it at Costco or PCC, but you actually have to look at the back of the supplement bottle, not the front, and look for this PAC or proanthocyanidin. The juice, unfortunately, doesn't really have it. And sometimes there's a lot of sugar in the juice, and particularly if you're diabetic, that's a problem because that actually increases your risk for infection. But the juice in general, the benefit to the juice is it just helps you pee more, and it helps contribute to the hydration. And so I don't mind the juice if it's going to make you stay hydrated. But overall, it would be that active ingredient that helps to decrease the risk for infection.
Great. So we'll have to take. No, it's wonderful. I'd love it if we'll record what you were talking about, what to look for. We'll add that to our information sheet. We just got a question. I'm just going to read it. Does vaginal estrogen use have any potential impact on your partner if you are sexually active?
That's actually an excellent question. Thank you, Lorna. And the answer is really no. So vaginal estrogen, when we use it usually twice a week. And like I said, it's ultra low dose. So the average dose we're giving is 10 micrograms of estrogen, and it's fairly quickly absorbed. So what I tell my patients is that if you're going to have sex on a night that you might use your vaginal estrogen, have sex first and then place it in that night before you go to bed. And so it's all absorbed by the morning time. It's not going to impact them the next day.
Great, thank you so much. Dr. Rubenstein, a couple questions came in about the DEXA bone scan. You were talking about in your 50s, you could get them, but how frequently should this be done? And then if you're over the age of 65, how often should you do a DEXA scan?
Yeah, I took a stab answering it, but I'll say for those who aren't reading, so most people are going to start at 65. If you're starting earlier, that means you're higher risk, and that may mean that you're going to have your DEXA scan more frequently. But for average risk women who start DEXA scan at 65, and the result is normal, then you may not need one for quite some time. There are varied recommendations. And again, you notice a theme here. And so it's really about having that healthcare provider that knows you really well and that knows your risk factors and that can make a recommendation on when you need to repeat. So for instance, if we do start a treatment, if we diagnose osteoporosis and we do start a treatment, we usually check in 1 to 2 years. And similarly, if you have what's called osteopenia, which is a pre-osteoporosis condition, then we're also going to be watching really closely, making that decision of when and it's appropriate time to start treatment.
Thank you so much. You know, I'm just noticing the time, it has just gone by really fast, and I want to make sure that we address questions and also transition from 60s into 70s and up. And so a theme that Dr. Rubenstein, I know that you face a lot in your practice is, what about cognitive health? What are some evidence-based strategies that we can follow, healthy aging for our brains? And then also, can you talk a little bit about blood pressure control, and then the thing about bone density and being concerned that somebody might take a fall? I know that's a lot of questions I just asked you.
It sure is, Lorna, but I'm happy to give it a try. So healthy aging is really important in so many different ways, but I think most of us really value our brain and our cognitive health a lot. And so what we're trying to figure out, I think, as leaders in aging is, what can we do to prevent cognitive decline and dementia? And it's a big topic, but interestingly, over the last year, some evidence-based recommendations have come out in terms of modifiable risk factors. So there are some risk factors that you can't do anything about. One is your age. If you're getting older, we so far haven't figured out a way to stop that. You can't change your genetics either. But the things that you can change, first of all, if we think about the entire age span, early education and lots of education protects and prevents folks in terms of later life cognitive decline. So think about that. In kind of the 40s to 60s, stress reduction, which has come up a lot today and is really, really important in these COVID times. Thinking about ways that you can reduce your own stress is an evidence-based way to prevent cognitive decline as we get older. And then it turns out that in the 40s to 60s, that's the age range where blood pressure control is really important. And so the reason that is because a lot of dementia has at least some vascular component. So there's Alzheimer's dementia, which is more common as people get older. And then there's vascular dementia, which can happen if people have either small strokes or large strokes. And so controlling for vascular health and cardiovascular health, cerebrovascular health by blood pressure control is really important in the 40s to 60s. And I say that because in the 80s and 90s, it seems to be a little less important to get that blood pressure under really good, tight control. So that's something that you're going to be wanting to talk to your healthcare team about. Depression. So another thing that is just more common in these stressful times that we're living in, addressing and treating, preventing depression and the social isolation that can again come along with some of the social distancing that we're needing to do. An interesting one is limiting head trauma. So if you're thinking about doing crazy adventure sports, wear a helmet. And then as people get older, like in their 70s, cognitive activity, so engaging the brain, is an evidence-based way to prevent cognitive decline. So those are just some really high level. There's so many other things, but those are the things that kind of have risen to the top in terms of evidence. In terms of the other thing you asked me to comment on was fall prevention. So there are a lot of things that affect whether somebody has an increased likelihood of falling. And so a big part of this is keeping people physically active. And again, harder at every age group because of the pandemic. And now, especially as we're moving into the winter, but keeping people moving, focusing on strength and focusing on balance as people get older. Interestingly, Tai Chi is a wonderful evidence-based fall prevention exercise that younger and older people can really benefit from. And then there's a lot of things that you're going to talk to your healthcare team about in terms of medications. So there are certain medications that, first of all, can increase risk of cognitive decline. And I'll mention sleep aids like diphenhydramine, Benadryl is a big one that a lot of people don't know about, but also in terms of fall risk. So medications, vision, footwear, home safety. And I'll just end it. I'll just stop there. It's a really, really important thing to talk to your healthcare team about, is how to prevent falls as you get older.
That sounds great. That sounds great. So I cannot believe how fast this went. We're going to put up some information about things that we should be doing to maintain a healthy lifestyle throughout our lives. And, again, we will share this information, so don't feel like you have to take notes. We will definitely send an email out. After our time together ends, there's going to be a survey that will immediately pop up. And so if you have further questions, please put them in there, and we will be sure to seek advice, or rather input from our physician panelists, and go from there. So we will start wrapping up our time together. Dr. Dunsmore-Sue, would you like to talk further about the Swedish Women's Health and GYN Specialties program at Swedish and the importance of philanthropy?
Absolutely, I would love to. So, and the name of this clinic has shifted over time, so we all say it slightly differently, but it's Women's Wellness and GYN Specialty Services, I think, our current iteration of the name. And, it really is meant to be a place where women can come for all of those specialty services that are needed as women age, and to help them maintain healthy aging. And the nice thing is it's integrated into the Swedish system. So the providers there will know where to find Dr. Nazemi, and will know where to find Dr. Rubenstein and her group, and be able to point our patients at those specialty services that are needed, as well as have some of those specialty services housed within our own clinic, which is great. And the importance of philanthropy really is the fact that, as Dr. Sorensen said at the beginning, it's been a really rough year for healthcare. And, we're trying to build a new service line and a new clinical space and all those things. And what philanthropy really does is allows us to get these things up and running before, the money is coming in from the actual services. We need to start the place and start the service line and start the clinic, and allows us to, recruit great staff and really make this the best clinic it can be. And I don't know if you are planning to, Lorna, but I just wanted to say, we got a great, wonderful donation of $250,000 from an interested patient, and I'm just thrilled to say that will go such a long way in helping us to really make this a reality.
Thank you so much. Everyone, if you could help me thank Dr. Dunsmore-Sue, Dr. Nazemi, and Dr. Rubenstein, and Dr. Sorensen for joining us today. We are thrilled that this Women's Wellness Series was so popular, and we hope to do more of these in the future. So as I mentioned, there will be a short survey at the end. And if you want to include topics that you'd like us to talk about, please do so. And if you're interested about learning more about the Women's Wellness Center, please don't hesitate to give me a call. I believe my information is on the screen. So with COVID, I hope everyone stays safe and healthy. And I thank you again for your time, and be well. Thank you very much.